Yep. Thank you for inviting me. It's really exciting to share my recent progress. I want to take your attention to the specific field for the diagnostic ultrasound. And then also I want to convince you whether I'm going to the right direction. So the title of my presentation is Transforming Medical Ultrasound for Advanced Critical Care. So as a disclosure, I'm a founder of the Sonics, and then the part of the contents are related to the company. So let me introduce my lab. My lab is doing the translational engineering. I'm bored with the conventional diagnostic ultrasound, so I'm developing the new form factor of the ultrasound and optical systems. So I'm just addressing different parts of the body using ultrasound modality and optical modalities. But today I'm gonna focus on the brain and also the pregnancy monitoring. So a medical ultrasound started from the A line. So they just to put the piezoelectric material, and then they found that the acoustic energy can penetrate through the body, and then we can detect the reflection. So from that simple idea, they have developed much of the thing, and then now we can see 3D and 4D dynamics in our body. And also they start to include some optical modality because it is giving more color into the image. So now the ultrasound imaging is quite colorful, so they can provide the structural information, but at the same time using the optical modality, like sending the ultrasound, sending the optical energy, and then getting the ultrasound signal, we can see the light observance inside our body. So it's quite promising for the future development. So I want, like, the main goal of this presentation is to take your attention to kind of paradigm shift about the diagnostic ultrasound. Like when we are talking about ultrasound, we are only talking about diagnostics, but also I want to bring it to the critical care medicine. So this is the field really dynamic, and then it really involves the preventive care, like without and with the presence of the disease. So they are just kind of being ready to detect any abnormal sign, and then the another thing is acute care. So whenever they detect the problem, they want to cure it as soon as possible. So it's kind of like really the philosophy itself is kind of waiting for the problem and then solving the problem as soon as possible. So here, the key component they are seeking for always as a researchers and clinicians is early identification of the problem, and then treatment, and then accurate guidance. And then the continuity is important thing in critical care medicine. So I want to kind of show what would be the conventional expectation, what would be the environment in critical care medicine. As you can see, the patient is quite vulnerable, and then like they can present any abnormal sign anytime. So there is so many devices attached to the patient, and then they are waiting for any number getting into the off from the normal. So that's what's happening in the critical care medicine, that this is really chaotic. So it's very specialized field, so that the clinician is trained to get into each of the number to decide whether the patient is okay or not. So in this chaotic nature, we just going back to the ultrasound. So ultrasound imaging is getting really popular in 1980s, and then the card type device was kind of inevitable because at that time the electronics was quite small and kind of like premature. So the card type was kind of the mainstream of the device form factor. And then as the electronic engineering has been evolved, there's a laptop type ultrasound system and then portable ultrasound system. And then these days, the clinician is just holding like a wireless ultrasound system, and then they are using their phone to find the image, and then they are reading out. But there's a same thing that has never changed since 1980s. That's a handheld form factor. So the clinician has to hold a probe, and then they have to manually scan the patient to find any abnormal sign. And then that needs a lot of training and then kind of time consumption for the clinical expertise. So there's already a problem with the kind of like a user dependency. The good sonographer will find many problems, but bad sonographer will find no problems. So there is some of the subjectiveness. And then if we want to bring this ultrasound imaging into the critical care medicine, the problem is amplified. So there's a usual independency. And then we are waiting for the problem. We don't know when the problem would happen. So, but the discontinuous imaging nature is not providing the good kind of understanding on patient. And then like once they start scanning, they cannot just kind of sitting down nearby the patient and then scanning for several hours. They just come and scan and go. And then like for the next scanning session, the problem can happen. So that is a limitation of the ultrasound imaging in critical care medicine. And then another problem is the shortage of the workforce. Like globally, the practitioner is quite short. So there is a many problem like to take the appropriate expertise to scan the patient in clinics. So in sum, like bringing the current form factor into the critical care medicine would be really, really challenging. So here, what I'm claiming, and then what I'm trying to convince you is to bring the wearability and then autonomy and continuity in ultrasound imaging in clinics. So like before, like instead of getting into like a big picture, like let's getting into the specific clinical problems. So I conceived that the kind of like a monitoring of the labor, like during the intrapartum monitoring, is the critical care medicine. And then like patient has to go through the 8 to 10 hours of the labor, and then the clinician has to decide whether to go with the vaginal delivery or the cesarean section. So cesarean section is only happening when there is a problem with the fetal health and labor progress. So since the 1970s, what clinician has been using is the electronic fetal heart rate monitoring, which is basically just putting the microphone into their belly and then listening to the fetal heart rate. So, but like when this get into the like a multi kind of center and then kind of decades of the retrospective study, what they found was quite disappointing. They found that it is ubiquitous yet flawed tool. And then when it comes to the brain monitoring, it has the 99.8% of false positive rate, which means that they are always alarming, even though there is no problem. And then due to this electronic fetal heart rate monitoring, the cesarean section rate has been soaring. It was like 10% like in 1980s, but now it is like more than 30%, which is kind of consuming a lot of workforce and then budget. So World Health Organization is defining this as a major public health concern, and then they want to develop the evidence-based guidance. So here, what I'm proposing is the mechatronic ultrasound. Basically, the idea is to resembling how the clinician is scanning the patient. So our device would have the core robotic scanner, that is the robot is holding the transducer by itself and then scanning the region of interest by itself. And then there is important organs we can monitor, the cervix and then fetal head, brain, and then fetal heart. Every important organ can be monitored consistently. So our idea is to collect the volumetric data, and then there will be the first layer of the artificial intelligence, so that it will be localizing where is the important organs. And then we can quantify how the labor is going and then fetal brain health by quantifying the oxygen saturation using photoacoustics. And also we can measure the fetal heart rate. So that would be the comprehensive information, how the labor is going, and then how the fetus is doing. And then whenever there is a problem, by using the secondary layer of the artificial intelligence, we can warn the clinician that this could be the potential risk. Then they can initiate their manual diagnosis or doing the intervention, including the C-section. So what we have developed is the small miniaturized robot that is holding the ultrasound array, and then it has the 3 degrees of freedom, which was understood by attending all the ultrasound scanning sessions in clinics. based on our collaboration with the clinicians at Hopkins. So basically, it will provide all the volumetric information, including all the regions of interest, and then measuring the quantitative numbers. So here is our device that will be for the better maintenance. So we have been making the tumbler design. So all the electronics and mechatronics is inside the tumbler, and then it will be maneuvered for the important organ monitoring. So here is a video how each of the degree of freedom works. So we can do the pitch, translation, and roll direction scanning. So from this device, what we are envisioning is not just providing just a one-time measurement of the fetal health or labor progress. We want to get the whole picture what's going on. So based on the very strong capability of the diagnostic ultrasound, we can bring all the parameters into the continuous monitoring workflow. So the first research would be actually we can be out of the hospital setup. So we can just make the patient wear this device at home, and then we can measure what's going on with the fetus in daily basis. And then also when they come into the birthing center, the device will be also providing how the labor is going and then how the fetus is doing at the same time. So we are moving forward with high self-confidence because we have been validating for this modality for past 8 years. So we went to the clinics and then we already validated that this device will just visualize what we want to see. We can see the fetal brain, fetal heart, and then cervix all at the same time. And then we also did the large animal testing using the pregnancy model, which is providing the quite reasonable scale of the fetus and mother as well. And then also we have been doing the extensive neonatal piglet experiment, which is resembling the neurophysiology of the baby quite well. And then we found that we can detect any abnormal hypoxia and stroke with a high sensitivity and specificity more than 90%. So like with all this biomedical imaging contrast, without autonomous workflow, everything will go back to the manual monitoring. So we have been developing the artificial intelligence agent. Like we started from the autonomous detection of the region of interest. So we are understanding the volume we collected and then finding out which is which. And then we can kind of pinpoint our monitoring on that regions of interest. And then there's a specific or like a kind of structure we want to see, especially for the brain oxygen saturation measurement. And then that task can also be autonomous by using the network. And then also, whenever we find the regions of interest, we'll be start quantifying over time. So using that data, we have to be able to detect any abnormal sign of the fetal health. So we have been developing the CNN network or the classifier to detect the stroke and hypoxia. So we are quite confident that if we just start delivering this device to the patient, we can detect the brain distress or other distress to the fetus. So based on the versatility of the mechatronics and also the versatility of the ultrasound imaging, we are also trying to extend our care for the vulnerable baby. So now the baby came out, but what if the baby is quite vulnerable so that it gets into the intensive care unit? There's several like a risk for the preterm babies. There is a stroke happening frequently, and then hemorrhage happen frequently. But this is also quite unpredictable events. Even though they are in the intensive care unit, what I heard from the clinician is that they do the echo session and then it was totally fine. And then like the overnight when they came in, the baby was seizuring. So when they are doing the echo session again, there is a hemorrhage. So that's a really, really problem. And then that is really making that baby's quality of life really, really low. So if we can find the problem in time with the continuous monitoring, and then we can solve that problem much easier. So in here, like the straightforward method we were thinking of is using the mechatronic ultrasound, just attaching it to the head and then making the rigid helmet. But we quickly realized that that is not feasible because the shape of the head of the baby are different. Some of them is having the cone shape, some of them having the round shape. So we are thinking out of the box. So like, and then like, if we are just using the mechatronic ultrasound, that will also bring the problem of the discontinuous monitoring, like the handheld way of imaging would not work. So out of the box thinking is get into the idea like disassembling the current form factor of the ultrasound, taking the individual element from the device and then making a modular piece of Lego. So we can assemble this Lego piece on top of the baby's head, and then the individual location can be tracked by the optical tracking. So by doing so, we can really, really reshape the helmet tailored to the patient. And then there will be giving a flexible imaging form factor. And then another benefit of it is that the aperture size of the handheld device is quite limited. But once we start kind of deploying the modular ultrasound, then the aperture size can be quite flexible, which will be increasing the spatial resolution and field of view. And also for the color Doppler, we'll be able to do the vector Doppler. So everything will be like improved. So now what we are working on is really the prototyping of the device. So we are envisioning like the baby is in the neonatal intensive care unit. And then there is an optical camera tracking all the individual ultrasound element. So based on the relative location of each of the element, we can reconstruct the volumetric ultrasound and photoacoustic imaging. So individual module will be consist of optical tracking layer and then ultrasound sensor layer and then optical illumination layer if the photoacoustic imaging will be involved. So we are now in a prototyping phase, and then the simulation shows really strong feasibility to see the like large region inside the brain. So if we are just doing the multispectral sensing, then it will be quantifying all the oxygen saturations. And now we are not stopping from the neonatal brain monitoring. We are also looking into the expansion to whole body monitoring. Like there is some instance that the clinician want to see the multi-organ activity, like everything is related. So for example, during the surgery, even though the surgery is happening in the distant organ, the kidney can make the failure. So if we can monitoring different organs with a wide field of view, that would be really great. So the modular ultrasound prototype was built, and then this is like happily, like it was reconstructed yesterday, but I'm really happy that we can show this image, that we can show the phantom contrast using the modular ultrasound part. So here's a summary. The critical care medicine has not fully explored in medical ultrasound due to the inherent limitation of conventional form factor. The manual scanning does not work. So wearability, autonomy, and continuity is the three keywords that I think the most important for the patient monitoring. And then presenting all these features in the new form of the ultrasound imaging has a potential to revolutionize the critical care medicine. And then all these form factor shift, like paradigm shift, has the inherent manufacturing challenges, and then which is where I'm seeking for the partnership with the Korean partners. So we are like the Hopkins is really interdisciplinary kind of like a melting pot. So we have a very good idea what would be really impactful in clinics, but at the same time, I studied in South Korea, so I know there is a many advanced manufacturing capability in South Korea. So I'm really seeking for the partnership with Korea partners. Thank you for your attention, and then I really appreciate with my collaborator and team. Thank you so much for your attention.